Welcome, I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Joining me today is Dr. Gilberto Salazar, an emergency physician at UT Southwestern in Dallas, Texas, to discuss a new virtual reality tool to help healthcare providers de-escalate workplace violence. Welcome, Dr. Salazar. It's a pleasure to have you join us today.
Pleasure so mine, Dr. Latter. Thank you so much for having me.
This is such an important topic, as you can imagine. Workplace violence is affecting so many providers in hospital emergency departments, but also throughout other parts of the hospital. First of all, can you describe how the VR program was designed that you developed, and also what type of situations does it simulate?
Yes, sir. We worked in conjunction with the University of Texas at Dallas. They help people like me, subject matter experts in healthcare, to bring ideas to reality. So I worked very closely with a group of engineers from their department in designing a module specifically designed to tackle what you mentioned is one of our biggest threats in workplace violence. So what we decided to do, Dr. Glatter, is bring in a series of competencies and proficiencies that we wanted to bring into the virtual reality space. In leveraging the technology and the expertise from UT Dallas, we were able to make that happen.
Okay, so I think it's important to understand, in terms of virtual reality, what type of environment does the program create? And maybe you can describe how a provider who puts the goggles on, what they're experiencing. Do they feel anything? Is there technology that enables this?
Yes, absolutely. We were able to bring to reality a series of scenarios, very common from what you and I see in the emergency department on a daily basis. And what we wanted to do is immerse a learner into that specific environment. We didn't feel that a module or something just kind of straight up on a computer or a slide set could really bring the reality of what it's like to interact with a patient who may be escalating, maybe aggressive. So we are immersing learners into an actual hospital room to our specifications, very similar to exactly where we practice each and every day, and taking the learner through different situations that we designed with various levels of escalation and aggression, and asking the learner to really manage that situation as best as they possibly could, using the competencies and proficiencies that we taught them.
Now, in terms of haptic feedback, that's an important part of the program, and also the approach and technique that you're using. Can you describe what haptic feedback means and what people actually feel?
Absolutely. One of the most unfortunate things in my professional career, Dr. Latter, is physical abuse suffered by people like me and you and our colleagues, nursing personnel, techs, et cetera, and resulting in injury. What we wanted to do is provide the most realistic experience that we could design. And haptics, what they do is they engage additional senses other than your auditory and your visuals. They really engage your tactile senses. And so these haptic vests and gloves and technology allow us to provide a third set of sensory stimulus for the learner. So at one of the modules, we have an actual physical assault that takes place, and the learner is actually able to feel in their body actually the strikes. Of course, not painful, but just bringing those senses, that stimulus, really leaving the learner with an experience that's going to be long lasting.
Right, and so feeling that stimulus certainly affects your vital signs. Do you monitor a person's or provider's vital signs, their blood pressure, their heart rate, as the situation escalates and the threat escalates? Because that could potentially trigger some issues in people with prior PTSD, people with other mental health issues. Has that ever been considered in the design of your program?
Yes, 100%. The beautiful thing about haptics is that they can be tailored to our specific parameters. And so the sensory stimulus that's provided is actually very, very mild. It feels more like a tap and more than an actual strike. And it just reminds us that when we're having or experiencing an actual physical attack that we're really engaging the senses. And so we have an emergency physician or an EMT paramedic on site at all times during the training so that we can monitor our subjects and make sure that they're comfortable and healthy.
So do they have actual sensors attached to their bodies that are part of your program or distinct in terms of monitoring their vital signs?
It's completely different, Dr. Ladder. We have two different systems that we are planning on utilizing. And frankly, the final version of this virtual reality module, we may not even involve the haptics. We're going to study it and see how our learners behave and how much information they're able to acquire and retain. It may be very possible that just the visuals, the auditory, and the immersion taking place within the hospital room may be enough. Very possible that the next final version of this, well, we may find that haptics bring in quite a bit of value and we may incorporate that. And if that is the case, then we will, of course, acquire different technology to monitor the patient's vital signs.
Clearly, when situations escalate in the department, everyone gets more concerned, obviously, about the patient, but also providers are part of this equation, as you allude to. There was a survey by the American College of Emergency Physicians in 2022 that stated that 85% of emergency physicians reported an increase in violent activity in their ERs in the past 5 years, and nearly 2/3 of nearly 3,000 surveyed of emergency physicians reported being assaulted in the past year. So this is an important module that we integrate, I believe, and certainly you believe, into training providers in terms of these types of tense situations that can result in not only mental anguish, but also physical injury.
100%. I frankly got tired of seeing my friends and my colleagues suffer both the physical and mental effects of verbal and physical abuse. And I wanted to design a project that was very patient centric while allowing our personnel to really manage these situations a little bit better. Frankly, we don't receive great training in this space, and I wanted to really rewrite that narrative and make things better for our clinicians out there while remaining patient centric. So I wanted to do something about it, and hopefully this dream will become a reality.
Absolutely. And just to mention, there are other data too from the Bureau of Labor Statistics that state that healthcare workers are 5 times more likely than employees in any other area of work to experience workplace violence. This could again range from verbal to physical violence. And so this is a very important module that you're developing. Are there any thoughts to extend this to, say, active shooter scenarios or any other high stakes scenarios that you can imagine in the department?
We're actually working with the same developer that's helping us with this VR module in developing a mass casualty incident module so that we can get better training in responding to these very unfortunate high stakes situations.
And in terms of using the set and the module remotely, certainly not requiring resources, having to be in a physical place, can providers in your plan be able to take such a headset home and practice on their own in the sense of being able to deal with situations? Or would this be more reserved for an in-department use?
That's a phenomenal question. I wanted to create the most flexible module that I possibly could. Ideally, a dream scenario is leveraging a simulation center, an academic center, and not just do the VR module, but also have a brief didactics incorporating a small slide set, some feedback, some standardized patients. But I wanted it to be flexible enough so that folks here in my state or in a different state or even internationally could take advantage of this technology and do it from the comfort of their home. As you mentioned, this is going to strike some people. It's going to hit them a lot heavier than others in terms of prior experiences, PTSD. And for some people, it may actually be more comfortable to do it in the comfort of their homes. So I wanted to create something very flexible and dynamic.
I think that's ideal. Just one other point, can you discuss the different levels of competencies involved in this module and how that would be attained?
It's all evidence-based. So we borrowed from literature in the specialties of emergency medicine. We collaborated with psychiatrists within our medical center, and we looked at all available literature and methods and proficiencies, competencies, the best practices. And we took all of them together to form something that we think is organized and concise. And we're able to create really our own algorithm, but it's not brand new. We're just borrowing what we think is the best to create something that the majority of healthcare personnel are going to be able to relate to and be able to really be proficient at. So things like active listening, bargaining, how to respond, where to put yourself in a situation, the best possible situation to respond to a scenario, how to prevent things, how to get out of a chokehold, for example. So we're borrowing from several different disciplines and creating something that can be very concise and organized.
Does this program that you've developed allow the provider to get feedback in the sense that when there's such a danger, their life could be at risk, that if they don't remove themselves in a certain amount of time, that this could be lethal, for example?
Yes, 100%. I think that that is probably the one thing that differentiates our project from any others is the ability to customize the experience so that a learner who is doing the things that we ask them to do in terms of safety and response is able to get out of a situation successfully within the environment. And if you don't, well, you get some kind of feedback, not to spoil the surprise here, but we're going to be doing things like decibel meters to see kind of what the volume in the room is doing, how you're managing the volume and the stimulation within the room. And if you're able to maintain the decibel readings at a specific level, you're going to succeed through the module. And if you don't, we just kind of keep the patient escalation going.
So there's a debrief built into this type of approach where, in other words, learning points are emphasized, where you could have done better and such.
Yes, absolutely. We're going to be able to get individualized data for each learner so that we can tailor the debrief to their own performance and be able to give them actionable items to work on so that it's a debrief that's productive and individualized, and folks can walk away with something really useful in the end.
And one other question, is the data shared or is it confidential at present?
At this very moment, it's confidential. We are going to look at how to best use this. We're hoping to eventually write this up and see how this information can be best used to train personnel. Eventually, we may see that some of the advice that we're giving is very common to most folks. Others may require some individualized type of feedback. So it remains to be seen, but right now it's confidential.
And one other question, is this currently being implemented as part of your curriculum for emergency medicine residents?
We're going to study it first. We're very excited to include our emergency medicine residents as one of our cohorts. That's going to be undergoing the module, and we're going to be studying other forms of workplace violence mitigation strategy. So we're really excited about the possibility of eventually this becoming the standard of education for not just our emergency medicine residents, but healthcare personnel all over the world.
Right. And I'm glad that you mentioned that because obviously nurses, clerks in the department, anyone who's working in the department for that matter, that interfaces with patients really should undergo such training.
Oh, absolutely. The folks at intake, at check-in, at kiosks, do they go through a separate area for screening? So you're absolutely right, Dr. Glatter. There are many folks who interface with patients, and all of us, all of them are potential victims of workplace violence. So we want to give our healthcare family the best opportunity to succeed in these situations.
Absolutely, and even EMS providers being on the front lines and encountering patients in such situations would also benefit, in my opinion.
Yes, absolutely. Behavioral health emergencies and organically induced altered mental status really results in injury, both physical and mental, to EMS professionals as well. And there's good evidence of that. And I'll be very glad to see this type of education make it out to our initial and continuing education efforts for EMS as well.
Absolutely. Well, I want to thank you. This has been very helpful. It's such an important task that you've started to explore and really look forward to follow up on this. And I want to again thank you for your time.
It's my pleasure. Thank you so much for having me.